All right. Hey, everybody. Dr. Rayfitch here. Good morning from Vet Triage. It is Wednesday, November 20th, 2024, 9:41 a.m. Pacific time. We are going through this veterinary surgery issue, and we are going to be talking about this paper and continuing with our palatal theme from yesterday, staged double layer closure of palatal defects in 6 dogs. This comes out of Cornell University, University of Davis in California, and a specialty hospital in Sydney, Australia. The objective is to report a staged approach that includes selective dental extractions before definitive double layer hard palate defect closure in dogs. Retrospective study, 6 dogs. Dogs had selective maxillary teeth extractions between 4 to 8 weeks before definitive hard palate defect repair by double layer local full thickness mucosal flaps. Results show that all palatal defects were considered complex. Complete hard palate closure was achieved after initial attempt in 3 dogs. 2 dogs out of the 6 had revision surgery, and 1 dog, the closure failed and further treatment was declined. No complications or long-term consequences were seen. Conclusion was selective dental extractions before definitive surgical repair using mucosal flaps in a double layer approach is an effective alternative when treating complex hard palate defects in dogs. So, introduction. Congenital and acquired hard palate defects are common in small animals. It results in poor nursing with growth retardation and or malnutrition, chronic rhinitis, and aspiration pneumonia. Hard palate defects are repaired typically using local mucosal flaps to cover the area and anatomically isolate the oral from nasal cavity. A common challenge is a large defect and a relatively small amount of soft tissue to complete the surgical repair successfully. Definitive closure of palatal defects often requires a multi-stage approach. Successful surgical correction also depends on the precise location and distribution of the defect, the integrity and quality of surrounding tissues, like healthy and intact mucoperiosteum versus fibrous tissue from previously failed surgical attempts, size of the bony defect, among other factors. The oral cavity of dogs imposes an additional challenge because of limited access and availability of surrounding tissues. 2 commonly used techniques for congenital hard palate repair is the von Langenbeck and overlapping flap techniques. For acquired hard palate defect repair, numerous flaps have been described, including reverse transposition and advancement flaps. These can be used alone when using a single layer approach or combined when using a double layer. Double layer techniques are preferred because they increase resistance of surgical sites when exposed to the adverse local factors inherent to the oral environment, like tongue movement, mastication, microbiological burden, and so forth. Failure of the defect repair using mucosal flaps occurs because of excessive tension at the suture lines when the size and configuration of the flap is not appropriate in relation to the defect size, shape, and location. Other cited causes for failure include infection of the surgical site, compromised blood supply, poor tissue quality, lack of underlying bony support at the suture lines, use of suboptimal suture materials, and or patterns, among others. A structure of critical importance when repairing these defects is the major palatine artery. Flap design and technique must aim at preserving this vessel whenever possible. Here is a picture there of a dog with scar tissue around because of previous surgical repair failures and a cleft palate there. And then there's a 3D reconstruction. At the very top is the front teeth, and then right underneath the front teeth is the palate defect. Let's see if I can show you this. Right there. This whole thing. And that's 3D reconstruction of the CT scan. Dental extractions in the proximity of a hard palate defect may be of value. The rationale is that performing these dental extractions, larger areas of viable tissue become available, allowing for surgical closure in 2 layers that comply with the previously mentioned principles. Materials and methods. Selective dental extractions before definitive surgical repair of hard palate defects, either congenital or acquired, by full and or half thickness mucosal and or mucogingival flaps opposed using a double layer approach. Intraoral examination was performed in all the dogs, full mouth radiographs, CT scan, three-dimensional CT. Selective dental extractions before definitive surgery were performed because the hard palate defect was considered too large relative to the soft tissues that surrounded it, making a tension-free closure unviable, or if the quality of these tissues, like from scar tissue, like we said, made it unsuitable for defect coverage. Before dental extractions, dogs had complete periodontal treatment, including supra and subgingival ultrasonic scaling and selective pumice or air polishing. The oral cavity was rinsed with 0.05% chlorhexidine gluconate solution. Infraorbital nerve blocks were performed with bupivacaine. All dental extractions were performed using surgical extraction techniques, and then a custom-made vinyl polysiloxone temporary obturator was placed on the hard palate immediately after extraction in 4 of the dogs. So then this orange structure there in that picture, the smaller square picture, that's the picture of an obturator that they placed. Definitive hard palate closure was undertaken 4 to 8 weeks later. Nasal cavities were then rinsed with warm, normal, sterile saline at 0.9% sodium chloride and suctioned. Oral cavity rinsed with 0.05% chlorhexidine gluconate solution and infraorbital nerve blocks. Hard palate defect closure consisted of creating 2 or 3 mucosal flaps to be opposed using a double layer approach. One flap was a reverse pedicle flap that hinged on the intact edge of the defect, and the other flaps were advancement or transposition pedicle flaps designed to cover the submucosa of the reverse flap, and in some dogs, the palatine bone that resulted from harvesting of the reverse flap. When necessary to secure the reverse pedicle flap against the contralateral side of the defect, several holes were created in the palatine process of the maxillary bone using small round diamond burr on an air-driven and water-irrigated high-speed handpiece, or Kirschner wire, also known as K-wire, on a hand chuck. The suture they used was 3/0 or 4/0 polyglycaprone 25 suture material. And then this is both intraoperative and drawings of the flaps that were being performed. So if you want to look at that more closely, then go for it. It's pretty cool stuff, pretty fancy repairs. Alveolar. So now a couple of different flaps. They were using alveolar and buccal mucosa pedicle advancement flaps, von Landenbach technique, direct apposition of tissues was repaired. Soft palate defects were repaired either at the same time or at later dates. Here's a cool picture of a flap being done. Look at that. Looks good. All right. Then after surgery, oral antibiotics for 7 to 14 days, pain meds for 5 to 10 days, then feeding only soft food for 14 days, no chew toys, no other activities that could interfere with healing, and then daily oral rinses with 0.05% chlorhexidine solution. Results. In, let's see, 4 of the dogs, it was congenital disease. 2 of them had traumatic oronasal fistulas. The defect size, shape, and location of the defects varied among dogs, ranging from complete midline defect of the secondary palate to round V-shaped or oval-shaped defects of varying diameters. 5 dogs had previous surgical attempts, ranging from 2 to 6 surgeries before this repair. Crazy. Chronic rhinitis, nasal discharge, aspiration pneumonia, and sneezing were all the clinical signs. The dog's age were 5 months to 3 years old, 4 male, 2 female. Intranasal foreign bodies was identified and retrieved in 3 of the dogs, and then another dog had nasal aspergillosis, which is a pretty bad fungal infection of the nasal cavity. Minor complications occurred during the hard palate defect repair in only 1 dog while harvesting the flap. Of the 6 dogs, complete resolution of the hard palate defect without the need for revision surgery was achieved in 3 of the dogs, so 50% success first attempt. Success returned. The success was confirmed at a 3-month or 6-month follow-up examination for the other dogs. And then 1 dog never healed, and they declined doing further treatment. Discussion. It has been suggested that animals with palatal defects are at increased risk of developing secondary nasopharyngeal infections. Achieving tension-free suture lines, maintenance of adequate blood supply to the flaps, gentle surgical manipulation of tissues, and adequate size of the flaps in relation to the defect are factors that play a role in the outcome. 2 layers of viable tissues covering the defect increases the resistance of the surgical site to the adverse conditions present in the oral cavity while providing connective tissue support to the suture lines. Additionally, revascularization of the tissue is promoted when submucosal surfaces of the flaps are opposed. Moreover, the flap should be larger than the defect. Similar to the staged nature of the approach we described for palatal defect repair, other techniques are based on the same principles. These include tongue flaps, soft tissue expansion, and osteodistraction techniques. The unique feature here we describe is removing the teeth. It has been suggested previously but not documented. The idea of removing hard tissues in proximity to the palatal defects in dogs is to increase the area of available soft tissue. For example, it has been suggested that portions of underlying bone structure, like portions of the maxillary and or incisive bones immediately around the defect, can be excised for the same purpose. However, removing bone underneath the defect will not only create a larger bony defect and a more invasive approach, but also further limit the possibility of achieving suture lines that are supported by hard tissues, and would therefore conflict with at least one of the surgical principles for palatal repair. Complications of dental extractions are rare. One consideration when using this approach is that selective extractions will need to be delayed until the eruption of permanent teeth for the younger dogs. Consequently, the overall success for the staged approach was considered high. And I would say, yeah, it's considered high, but I mean, it's only 6 dogs. I know it's a common defect, but not commonly sought after for repair. It has a really high failure rate, and so you want to have more dogs in future studies, of course. The use of adequate suture materials and patterns are important as well. Closure of all extraction sites and flap apposition is performed using polyglycopyron 25 in a simple interrupted pattern. Simple interrupted pattern is generally recommended to decrease the chance of dehiscence of surgical sites in the oral cavity. This suture material produces the least number of side effects for oral soft tissues. The obturator is used between the selective dental extractions and definitive closure, allow temporary relief of clinical signs and local control of secondary inflammation. Nasal aspergillosis interfered with healing, that's suspected anyway, in the one dog that didn't heal. The quality and vascularity of tissues in some of the other dogs with scar tissue do not allow adequate healing of the flaps. Healing of denuded palatal bone by granulation tissue typically occurs uneventfully about 3 weeks later. This is in contrast with non-completely denuded palatal bone, which takes 2 weeks to heal. Additionally, it is believed that achieving complete closure of denuded bone reduces post-operative complications. And there you have it. That's it. So pretty cool. I love seeing these kinds of techniques, especially with these animals that probably would have been euthanized otherwise. And we'll continue tomorrow with another article from this journal. We'll see you guys then. Thanks for those who are watching the playback. Bye.